clearly IT, communications technology, is an important enabler of the work that we do. We've been crying out for it for years, and it's coming on stream. In many ways has come on stream for many groups, further on than many might think, and in fact further on than other jurisdictions. You go into other jurisdictions and they point proudly to what they're doing, and you think, I think they've been doing that for a year or two in New South Wales, and it's true. So we have come a long way. The trouble is, it's slow, it's incremental, and you look around after 5 years and realize how far you've come, rather than the king hit. Even the PCHRs like that. Big expectations. It's going to be a lot different in a year's time, and it's certainly going to be a lot different in New South Wales as you add the functionality that you need. And in Victoria, for example, they're adding advanced care directives to it, and we'll be able to have access to that sort of technology too. So it's really an important enabler. And so this next session is on that. We'll try and get some audience participation. The program's really tight, but we'll see how we go. To run the first part of this session and just present some key innovations is Michael Walsh, who's Chief Executive of eHealth New South Wales. Please welcome Michael.
Thanks very much, Norman. I'd like to acknowledge the Minister for Health, Gillian Skinner, and the Assistant Minister for Mental Health, Jai Rao. I'd also like to acknowledge the traditional owners of the land upon which we meet, and particularly the elders past and present. Well, welcome to the new digital era. As the old saying goes, I hope you live long and in interesting times. We are indeed living in interesting times as we experience the benefits and the challenges of moving from old paper-based systems to new digital systems. As we move into this world, we don't want to transfer the old practices that we had from the paper-based systems that were because of constraints of that system. We want to take advantages of the new digital way that we can actually use our services. We have to remind ourselves that eHealth is not a journey in itself. eHealth is to achieve benefits for patients and for clinicians and for the healthcare system generally. It is about improving health outcomes for patients so that they have reduced clinical errors, there's evidence-based treatment pathways, patient information can be available wherever the clinician or the patient is, multiple entry can occur by clinicians at the same time, patients can access their records when and where they want to, and the safety and quality of the healthcare we provide is improved. As we achieve and work towards achieving these benefits, we need to be very clear about 3 areas that we have to progress at the same time. We have to ensure that the functions in all of our clinical systems actually meet the needs of patients and the needs of clinicians. It needs to be meaningful for it to be useful. The next thing is, whatever we do in eHealth has to be usable. We all remember our first experiences with computers and how difficult it was for us to understand them. As we develop new initiatives, we actually have to make them easy to use and for people to understand. Finally, they have to be available. We have to have the networks and the infrastructure in place to be able to deliver the applications via wireless, by networks across the state, as well as by mobile handheld devices and also fixed computers. Today we're going to talk about 4 initiatives that are touching patients directly. Those 4 initiatives are telehealth, community nursing use of mobile electronic patient records, mobile bedside menu ordering, and a home dialysis app. All of these are either currently being used or in trial or pilot phases. I get the pleasure of talking about 2 of these and then hand over to other people to talk about 2 of the others. In relation to telehealth, the important thing about telehealth is it allows secure communication. In other words, communication where people can be confident that any clinical discussions they're having are between them and the person on the other end or the people on the other end of the telehealth session. The benefits of telehealth are to ensure that patients can get access to specialist care without having to travel large distances. It actually assists patients to become more engaged in their own self-management. It allows patients to stay within their home and near community and have access. and it also improves health outcomes as people become more understanding of in actual fact, their health treatment and care plan. Currently, New South Wales Health has telehealth operating in multiple areas across the state. The real development at the cutting edge of telehealth is moving from beyond just it occurring between one clinical health setting to another clinical health setting to being able to occur in a patient's home or a service outside of New South Wales Health, but still remaining secure and still allowing voice and data and picture to travel across the session. The other initiative we will be talking about, and I will be showing a short video on these two in a second, is the community nursing use of mobile computers, so that when they're in a patient's home, they're able to access that patient's electronic health record directly. They're also able to access any information that may be available to help with the discussion with the patient. It's really clear that as the mobile devices that we have become smaller, and the mobile broadband networks that we all take advantage of now become faster, we can actually transfer large amounts of data and therefore have the electronic medical record available in a person's home. It is allowing patients to feel more confident that as they're talking with the clinician, the information's going directly into their record and is available to other clinicians working with them. They are able to do appointment scheduling as community nurses move from house to house. If an appointment has to be scheduled, they can actually get that rescheduling on the go and not have to come back to the office in order to have a rescheduled appointment. There's access to clinical information and they're able to fully discuss the patient's details. I'd like to finish my session now by showing you a very short video highlighting the benefits of telehealth and the community nursing use of mobile EMR.
eHealth New South Wales and local health districts across the state are combining technology with the best in medical and nursing care to deliver safer and more comfortable healthcare experiences for patients.
Every day a nurse comes in each morning to give me my medications because I can no longer see to do it myself, and they give me all my injectable medications and my liquid medications and my medications that are by tablet. I think the best thing so far has been the nursing staff coming and caring for me, because that's been great, and because they've now got these computers, what they write in there, my doctor can see, and she can see if the nursing staff have been worried about something. I'm looked after by a rheumatologist. I'm looked after by a palliative care doctor. I'm looked after by a ophthalmologist, and I'm looked after by a psychiatrist. So all of those doctors are able to have a look and see.
Community nurses from Sydney Local Health District are now able to enter vital patient notes directly into the electronic medical record during their home visits.
The benefit from my point of view is that while I'm talking about it, the nurse can be entering it in straight away, and she then can listen to what my complaints are and be entering it in. And if she has to go away and do it somewhere else, there's that concern that she's not entering in what I see as being the problem. So I think being able to enter it in there and now is great.
Patients in remote areas of the Hunter New England Health District and other parts of New South Wales are now able to have a consultation with their specialist via video conferencing, saving them many hours of travel, cost and potential discomfort.
To be able to do the video consultation, it was a great relief, because we've only had to travel 40 kilometres, half an hour's drive, as opposed to 504 kilometres from Benny Guy to John Hunter, which would take us 6.5 hours. for what? We say 15-20 minute consultation, half an hour tops.
And then turn around and come back again.
Hi, Lauren and Mindy. My name's Rachel Sullivan. I'm one of the doctors working here. This is Jenny Rutherford, our cancer care coordinator. Hello, Lauren.
Hello. Hello,
How are you
girls.
doing?
Yeah, not too bad. Yeah, not
Thank
too
you
bad.
for coming to the teleconference appointment.
I think it's great because if I went to Newcastle, I'd have to have someone to come with me, with like a carer.
Over the past 2 years, one specialty clinic alone has saved patients over 110,000 kilometres in travel.
You have to stay somewhere that night. You have your consultation the next day. You're not going to travel back that day. You have to stay again, come home the next day. Moorie's our shopping centre. It's our centre for everything. So you can just include that consultation in with any shopping, library, whatever you're doing.
I've never heard of it before, the video system. I was really shocked when she rang up and told me about it. Yeah, and I don't have to travel all the way to Newcastle. I think this is a great idea.
It was very comfortable. It was good, yes. It was pretty much the same as being in person.
I'd like to now ask Carmen Rechbauer from HealthShare to come to the stage in order to talk about the direct menu ordering electronically at the bedside for patients.
HealthShare is about to take food services into the 21st century in 2015. Our current processes are up to 30 years old, using paper menus, and technology is actually going to help us transition without adding additional cost. Currently, patients order up to 36 hours ahead of eating. Now, that's not normal for us in everyday living, let alone being sick in a hospital and not knowing what you're going to feel like in 36 hours. Our food service staff also visit the patient up to 12 times a day, but actually have very little interaction with those patients. We waste an awful lot of food because of those delays. Up to 50% of patients in larger hospitals don't even get an opportunity to order their food because of the processes. We're completely process-driven. We're not patient-focused yet, but we will be, and we're working towards it. Today, Kerry Balding, who is our IT person in food services, we're going to provide you with a bit of a demonstration as to how we're going to use technology to allow us to speak to patients about 2 hours before they're going to eat, which will be a vast improvement. Kerry?
Okay, it's 2015 and we're going to have some changes. It's 10 a.m. and the staff taking menu selections for today, for lunch today, are actually on the wards talking to the patients. And this is what it's going to look like. We've got a tablet. Sorry, we've got a tablet and the food service staff members on the ward, they take the tablet up, they bring up a patient list, they can see who we still need to see and take their selections. We can also see who has diets and other information as well.
So I'm going to be the patient.
Okay, so this is typically how it goes. Hello, Mrs. Jones. My name's Kerry, and I'm here to take your food selections for lunch. Would you like a hot meal, or a salad, or a sandwich?
I'd like a hot meal, please.
Okay, we have beef and tomato casserole, crumb fish, or bolognese.
I think I'll have the beef casserole.
So we would just be tapping on the iPad to take the selections.
Just as I tapped on the microphone.
Thanks. Okay, would you like mashed potato, pumpkin and beans with that?
Yes, I would, but hang on a sec. I don't like onions.
Okay, so let's have a look at what's in the beef casserole. So just by another click, we can see the full ingredients for that product. So we have a look, and yes, it has onions. Sugar, what have we done? Sorry.
At least she said sugar.
Okay. So
That's
now
true.
we can choose something else. The patient can change what they would like.
Did you ask me?
Yes, you said you'd have the
okay.
fish instead, sorry.
I'm going to have the fish instead, thank you.
Okay, so would you like the cream caramel for dessert? It's pretty good.
Well, that sounds good. And can I have some juice too?
Great. So then we've got some extra features that if the patient's on a special diet, then, and they say in this case that they'd like some potato wedges, there's going to be a message come up saying that this is not great for your diet. And then you have to have special security to okay it. We can also see nutritional data if we want to. So this is how it's going to happen. It's going to be on the wards. We're going to have our staff talking to the patients. And because it's a component of our current Seaboard dietetic and food service software, we're actually going to have real updates by PAS and EMR into our system. So the staff are going to be on the wards knowing what goes on, and the information's immediately available for food service staff. So I think we've just skipped ahead a bit.
Yep. Okay. You right?
Yep.
That's it?
Yep, just this side.
Okay. So, after that little demonstration, which you can see that we didn't do a lot of practice on, but that's pretty much how it will work in the wards, which is very different from today. I guess the key benefit out of having the tablet technology and being able to go and talk to the patient is that we'll actually have a connection with the patient. It'll be people working with people, food service staff working with patients, and that's really what we're after. Thank you.
You don't want the last one?
No, that's fine. Keep it on. I'd like to now introduce Tanya Baldacchino from Nepean Blue Mountains and Dr. Jamison King to talk about the home dialysis app.
Thank you for the introduction. I'd just like to provide a little bit of background about Nepean Blue Mountains Local Health District. So we received from the state government some funding to develop and implement innovative telehealth initiatives. And with that, we've created the Nepean Telehealth Technology Centre. Our focus here is on the development, evaluation and implementation of best practice telehealth technology with a specific focus on improving patient access to care and improving health outcomes. We have a unique partnership with the University of Sydney, and this allows us to introduce state-of-the-art technology, and so we can customise specifically to each project meeting the needs of the patients, the staff and the community. So home dialysis is a self-management approach to a chronic condition. Western Renal Services encompasses 2 local health districts, and it's one of the largest home dialysis therapy populations in Australia, with more than half of their patients dialysing at home. Currently, there are around about 110 patients on home hemodialysis, and that's the focus for our project. Challenges include such things as limited nursing resources, and this limits ongoing support to the patient. So the Western Renal Services covers 87 suburbs with a nurse-to-patient ratio of 1:36. So what we've done is develop a technological solution to improve and simplify patient management and clinical support. We'll now show you a short video which demonstrates the application of the home hemodialysis app and web solution in a real-life situation. Some dialysis patients are treated at hospital, but others choose to stay at home. Western Renal Services are one of the largest in Australia. Each patient records information of their dialysis sessions in a logbook. This large amount of handwritten information can be cumbersome, making it difficult for the specialist or the nurse to identify trends.
But it's really cumbersome. They could be ringing me and talking about numbers. It's hard for me to envisage, to visualize the whole scenario.
Our Nepean home dialysis app is designed for home dialysis patients to record their information electronically and to assist in calculating goals. As the patient record grows, the app shows the trend in a graph.
Whereas if they enter it into an applications, the treatment data that they enter are reflected in my computer in real time. So if they're having some concerns or questions, they can just ring me and say, hey, can you open up your screen and look at my treatment data? You are aiming for a dry weight of 7 to 8.5. And you are doing 5 to 6 hours. It actually gives me about 4 weeks in one screen, 4 weeks worth of treatment. It also computes the average weight gain of a patient, the average blood pressure over the 4 weeks. So it gives me an indication on whether this patient is fluid overloaded or dehydrated.
I think it's a lot better because when I have my appointment with a specialist, instead of carrying the book with me, my phone is in my pocket. It just show the doctor instantly. And the other advantage is the nurses in the center, they can view it. They can have like a graph as well, a graphic. They know what's occurring, whether I'm doing the right thing, whether I'm taking too much fluid out in too short period of time or things like that. And they can monitor my blood pressure as well. They can tell me if something is going wrong.
I used to see patients in the clinic where patients would come in with an exercise book, 3 or 4 pages of data on the treatments that they've done at home over 2 months or 3 months. And I just didn't have a clue as to what I could do with that data. So I decided that there could be a better way to look at dialysis parameters. We could get rid of the variability in pre and post dialysis weights and blood pressures and flow rates, and kind of map them in an app. The future is great. I think we can do a lot with patients at home, and we sitting in our offices and clinics, and do things that are more efficient and that promote patient independence.
So working closely with the patients and the health staff, we developed this app and we got it running on 2 most popular platforms, which includes Apple iPhone and also the Android devices. What they can do, as shown in the video, it has features such as alerts, their goal settings, and also reminders and other schedules that they have to add to. But also, if they choose to, they can push the secure cloud. We are looking into technologies such as PCEHR, so they could actually use that to send their data, but also new emerging fields such as Apple's Health Kit, where people are starting to now use it as part of their health record system. Of course, some patients, if they don't feel like to use network-based cloud system, we do have an offline version where they can save everything, and once they connect to a computer, they can print out a copy. And with the copied paper, it still has all the benefits of graphs and charts that the nurses and physicians can quickly interpret the data. And also, part of it is that because it's a digital record, it can help us in activity-based funding. So I'd like to pass back to Tanya.
So just to highlight some of those benefits mentioned. So it's a simple and easy way to view dialysis data and trends. It's real-time information, and it results in improved clinical decision-making assisted by the use of a mobile app. It's efficient and easy record keeping for the patient, and it's been developed with the patient and it's for the patient. Results in less travel time for patients and staff, best practice around security, training and documentation, And it also allows us to capture the number of treatments accurately per month for activity-based funding purposes, as mentioned. So the future is looking bright, and what we're looking at is recruiting of more patients in the near future, incorporating the home hemodialysis app with the training of new patients coming on board. We will be implementing video consultations between the patient and the nurse back at the clinic. We will look at linking the home hemodialysis app with other health databases, such as the renal database. The peritoneal dialysis app is also in development. And looking into the future, we'd like to look at remote stethoscopes and vascular ultrasounds to monitor the dialysis access. Thank you. Just like to acknowledge Western Renal Services and our research students at the University of Sydney. Thank you.
So where did you find the 14-year-old boy to do it?
So part of this...
You're the 14-year-old, are you?
No. Part of it is a unique relationship with the university. And university, we have many keen students who really believe that they can contribute to healthcare and make a difference. So we are very lucky to work with them.
And other local health districts can get this app if they want it for
Yeah,
their renal
so
services?
currently it's available on both the Android App Store and the Apple Store, but we are on pilot stage, so you do need an access code at the moment. But our goal is if we can roll out to everybody. Yeah.
Great. Well, thank you very much. That's fantastic. Thanks. We're going to have a panel discussion now just on the issues around eHealth. Oh, some of them are already up there. That's great. And so our panelists are Michael Walsh, who's already been introduced to you, John Lambert, who is Chief Clinical Information Officer in New South Wales, Mary McCaskill, who's Director of the Emergency Department of the Children's Hospital Westmead, Katharine Duffy, who is Director of Nursing and Midwifery at Sydney Local Health District, and Mary Potter, who's on the board of Health Consumers New South Wales. So get your little devices out. And what you've got to do, most of them you're making 3 choices. And if you press the buttons and don't press send, nothing happens. So you make your 3 choices, and then you press send. Easy. And because this can get as boring as all you make out, we're only going to give you 10 seconds to answer. So you've got to be quick. I'll give you time to think about it. And what I was going to do, you'll see that you've heard the panel discussing is what you'll see coming up on the thing. I'm actually going to run through these questions with you, because what I want to do is have a panel discussion uninterrupted, but interrupted by you. So I want you to join in the conversation about anything to do with eHealth and eHealth applications and issues around tailoring them to patients and efficient healthcare. So let's take the first question. So you've seen those applications. From your point of view, even though I'm going to get to an expanded list in a minute, which in order of most to least beneficial to patients, which would you guess is the most beneficial to least? And make 3 choices. I'll give you have a think about it for a moment. So you're doing your 3 top choices in order of preference, and then you press send once you've done it. And we'll start the clock now. So Telehealth wins, and community mobile computers, dialysis app. Let me tell you, patients probably... Mary, what do you think? I think patients probably care about their menu more.
Sorry, what was that?
I think patients probably care about what they're eating in hospital most.
Yeah, well, certainly having been in hospital and received the menu a week in advance, this sounds wonderful.
Yes.
But I think if I lived in a remote community, I think telehealth wins hands
Absolutely.
down. Yes.
And to be serious, it's interesting the spread is quite even, because all those applications are incredibly beneficial and important, and including telehealth. Let's go to number 2, because question 2 is a more expanded list, which gives you a few more options here. Again, you're only going to be able to choose 3. And have a moment to look at it. So it's telehealth. It's basically the ones you just saw. E-referrals from GPs to outpatient clinics. Online appointment scheduling. There's currently probably 4 or 5 businesses, startups in online GP consultations. It's a hot area for technology investment. Hospital information and personally controlled electronic health records. Real-time electronic patient feedback at the end of care episode. Well, that's risky, isn't it? Direct patient access to the healthcare plan. So choose your top 3, have a think about it for a moment. Remember, it's your 3 choices and then send, and go now. So telehealth still wins. And again, a pretty even spread, suggesting that most people think that they're all pretty important. So that's great. Thank you very much for that. And question 3, this is you deciding this. How are you going to know that this is actually what your patients want? So how are you going to engage your engaging patients to actually ensure that care or what you're developing is actually suitable? So is it feedback at the end of the care episode, focus groups on patient initiatives, written surveys, testing your applications before going live, direct discussion with the care team, online fora, or social media? What would be your top 3 ways of engaging effectively with patients? And start voting now. Yep, that looks about right, Mary, don't you think?
Definitely. There's nothing like face-to-face communication, and if we're considering the whole age range of patients and backgrounds, the face-to-face is the best.
And at the end of a care episode when it's fresh in everybody's mind.
That's right.
How practical is that, Mary? Particularly in a busy ED.
Well, I think patients often complain that they sit around with nothing to do. So, in fact, often they want us to hear what's happening. So I think we need to utilise those opportunities. And when you look at the private sector, not private health, but when you go to the hotel, they ask you what you've thought about it. When you go to a restaurant, they ask you what you think about it. So I think we're quite used to giving our feedback, and I think we should incorporate that.
So when was the last time when you were in a hotel you actually filled out that form?
I always fill it in.
Oh, gosh.
Because I like to tell them how nice it is, and so next time I come, they might upgrade me.
I only do it when there's been something bad happen, which is... So in a general sense, Katharine, what do you think in terms of that end of care episode feedback? I mean, to do it on paper is going to be a nightmare. One really does need to do it electronically, doesn't it?
Yeah, I think the electronic method is certainly beneficial, but you know, I think nothing beats actually sitting down with patients and really talking about their experience and doing it at the time that they're having that care. It is far better than waiting for them to go home, because there's often lost opportunities there. And I think it's opportune to be able to talk to them also about some of the things that perhaps are in the pipeline that are addressing the things that they've raised.
So John Lambert, in technology circles there's a term called airware, which is people talking about software that is, you may have a 14-year-old working on it in the background, but essentially it's not there yet. So of that list that we saw there, how much is there? How much is not airware?
How much is there anywhere in the world, or how much is there across New South Wales facilities?
Our world is New South Wales.
Can I have a look at the list again?
Yeah,
no, not trying to dodge the question. In an integrated fashion across all facilities, not a lot. And some of the requests let's look at telehealth. I'm actually pleased to see how popular telehealth is. It's one of my pet interest areas. But in fact, we aren't doing that, exactly what you saw in that video, everywhere it needs to be done. So we have lots of great pockets and fantastic innovation here today, but it's not necessarily everywhere it needs to be yet.
So I'd be interested to hear from you on telehealth. I hesitate to say that there's a jurisdiction but Queensland has spent a lot of money on telehealth. They've got robots doing child ward rounds in regional hospitals with a paediatrician sitting in the Royal Children's doing it. You've got one full-time oncologist in Townsville doing nothing but telehealth oncology. So they're obviously doing a bit more than we are. What barriers have they got over, John, that we've yet to? And I'd be interested to hear from you about what barriers you need to get over to be able to organise efficient telehealth. It's clearly important to you, and it's clearly important to patients.
Look, I think the history of nearly every telehealth project I've heard of is about the clinical drive and the interest of the clinicians in wanting to deliver the service that way. I think anybody can look across New South Wales and find that there's telehealth equipment everywhere. There are some technical barriers, and the improved networking that's being rolled out as we speak will help with that, but that really isn't an excuse. We've been able to do telehealth video conferencing based, as we saw there, for a long time across the state in pretty much every facility. And the reason it doesn't happen is perhaps the interest, the organisational barriers, just trying to manage the waiting list, and you need somebody to escort the patient into the room. It's often human and cultural, not technology, in that particular example.
Katharine, have you got much experience in the local health district of telehealth from a tertiary referral centre?
Not directly, but I actually happen to be a renal nurse by background.
Just hold this really close.
Happen to be a renal nurse by background, so I have a particular interest in telehealth in terms of dealing with the rural population. And certainly it provides a great deal of security to patients to be able to access information and care from the entire healthcare team when they need it.
So Mary, people will say, oh, well, the bulk of our audience, our patients are elderly and they're not tech savvy and they'll be alienated by this. What's your answer when people throw that in your face? Not that you're elderly.
Well, I think society is changing, but that is a real issue, I think. But if it is set up, we saw the example of the community nurse coming in, and I think that perhaps you can use some form of community nurse involvement to set things up and to be on call. Obviously, there will come a time, or with certain illnesses, where it's not going to work. But if somebody is as frail or not able to think as clearly, they're not going to be living at home, so they will have somebody who...
And it's the fastest growing group of users of social media, the internet, and my understanding is that this is a myth. People who are older and retired have the time to actually play with this technology, and they are doing so in large numbers. I
think that's true. I don't think we can quite beat the 14-year-old though. But,
well, I don't think you want to, actually. Michael Walsh, just sorry, there's one more question I wanted to ask you, Mary, before we go on, is that you can get a good idea in innovation and go down the track of developing it, but it's not actually what patients want or need. What do you, and what we got, it was a very general question that about what's the best way to engage patients. But if you've got an idea as a clinician about an application that you want to develop, what do you think would be the best way of consulting with patients to make sure it is something that they would want or need?
Well, I think there's probably two general approaches. I think most health districts have got some form of community participation group.
They do.
And there's the organisation that I'm involved with, which is Health Consumers New South Wales, with a large pool of members. They could give direction. And also, we shouldn't forget the peak body of Consumer Health Forum, who may well have appropriate members in New South Wales that you could call upon.
I didn't ask Jinmin the question, Michael, but the development cycle. Often what happens in eHealth is that you're so risk averse that it's got to be perfect before you actually get out there to the market. You spend a lot of money and you find out it's not right. What do you think is the ideal, for those of people in the audience thinking of developing new stuff? And of course, this conference is all about encouraging people to get out there, take calculated risks, be prepared to fail. What do you think is the right kind of way of thinking of the development cycle of new products?
Thanks, Norman. I think you have to have two cycles going on in health, in eHealth. One's a long-term cycle that gets the foundation areas in place. So you can't have a rapid cycle around having an electronic medical record. That's a long planned cycle. However, you can have things like the dialysis. And
that's a long planned cycle because of privacy, security,
complexity,
common language, and that sort of stuff.
Yes,
it's not as easy as you think.
Not as easy as you think. But you have to have that in place, and New South Wales is really well placed where it has the EMR in place, it has HealthyNet that links to the PCHR. We have all the foundations to allow innovation, like we've seen around the dialysis app, to sit around that. And those cycles of development should be faster. And we should be doing those, we are doing those, the same way that the tech industry does it. And that is, you actually have to have a number of things running, some of which will fail. And we have to accept that they will fail and go nowhere. but that isn't in fact the better way to proceed.
So be prepared for, don't wait for perfection. Get out there and actually test it, then refine it.
Yeah.
When you don't do your whole budget up front. Keep it back. Teresa? Do you want to just get right in front of that microphone?
Thank you. Michael, it leads on from that question, but there's so much that's happening in the e-health space and so much investment that we can make. How do we prioritise it? How do we make the wise decisions?
That's the $64 million question. About the same as we spend on capital. The challenge is, in fact, listening to patients in order to make sure that what we're putting in to the health system makes sense. I actually think that my takeaway from the responses that came to those questions was that healthcare is, in fact, a human interaction. And that requires trust, and people are involved. So when you looked at the ranking of responses, telehealth, which still had that personal connection enabled by technology, was ranked highest. Then talking to someone at the end of the care being electronically recorded, and as we went down, we got further away from the person, from the human interaction. So I think that's a message to eHealth. But I think that the challenge is balancing the expectations that people want to see rapid innovation around the interactions with clinicians and patients, as well as continuing to build the foundational elements. And I think, Teresa, the short answer to your question is we have to do it in consultation with our clinicians and with our patients, because eHealth...
But an important criteria, which I think is what Teresa was getting at, is the feasibility of the technology. In other words, if you're going to come up with a great idea and wouldn't do it, but if the technology is not there, ready to do it, is this a feasible thing? I mean, that'll either facilitate it happening very quickly or kill it. Won't it?
Indeed. If I use telehealth as an example, when we think, and the people in this room would have all been involved in telehealth when it first started, and they were big, expensive machines that no one could actually use because you had to get the technologist in to actually set it up. And we have gone through a number of iterations, and now we've actually built video collaboration. And video collaboration allows an invite to be sent from a clinician to a patient's home computer to have an interaction securely. And in other words, getting back to Mary's point and your point about are our patients using their technology, and the answer is yes. And where they are, we've now moved into a new era of telehealth. And that will always be the case. We'll always start and have to progress.
And then the question then is, if you've got a good idea, which comes back to Teresa's point about priorities, is there some place, or are we going to get to some place where you can quickly find out that there is an enabling technology to make this happen, or have you got to rely on having a 14-year-old child to tell you?
I think I'd like to make 2 points in response to that answer. I think when we look at systems like health, which are large and complex, actually reconfiguring them to be able to take advantage of the modern mobile app environment itself requires a lot of re-architecture and rebuild work. So we're doing that. The second thing is, getting back to your point, I think when we look at how we use applications in our own lives, and this is just a personal anecdote, we'll use a map app on our phone to see where we need to go. We'll then use a weather app to see what's it going to be like in terms of raining. We'll use a public transport app to look at when are the trains or the ferries running on time. And we'll look at a live traffic app to see, have we got to... What in health our problem is, we want, before we produce all those 4 apps, we want to be able to have an app that balances the weather and gives us a rating over whether we should go public transport or car, and wants all that together in one app before we put it out. And the reality is, as you said, that takes too long. We've got to be prepared to put out the single apps and in time develop those.
And then move forward. Let's take some questions. You've been waiting very patiently there. Could you introduce yourself as well? Thanks.
Jenny Saunders from Western Sydney. I'm an urban person. All the resources I need quite local, but I wonder what telehealth is going to do about, if I want to see a specialist, I have to go to a GP first. Every time I want to see a specialist, whether it's oncology, cardiology, whatever. Does telehealth address the need to, all these multiple trips to the GP to get referrals, to make the contact with the specialist?
Very good question.
I think it's an excellent question. I don't think it's one that eHealth is able to necessarily address. The referral patterns are really policy decisions, and eHealth can enable consultations with GPs and consultation with specialists, but those policy decisions are not eHealth's.
But of course, coming to other issues, with team-based care increasing, then your team might enable you to have access to the specialist care you need without having to go through specialists, your GP for referrals all the time.
But even if you get a specialist, like an oncologist, every year you have to go back to the GP and get yet another referral, and it's so time-consuming. Doing it in the city is one thing, but for the people out in the bush, it's a big deal.
Thank you for the comment. These are, note taken. The issue is that GPs in the system are the gatekeepers and a way of controlling costs, but it does create those inconveniences. I don't think eHealth's going to solve that. Sorry, you were next.
Hi, I'm Perry O'Shea. I'm from New South Wales Consumer Advisory Group Mental Health. I guess mine's more comments than questions. There's two, I guess. One is that video conferencing has really revolutionised things for consumers within rural and remote areas in New South Wales, but it still could use a lot more of that. But the second thing I really want to talk about is that in mental health in the public sector, we already have quite a good discharge consumer perceptions and experience type survey and process, quality improvement process. And we're looking at the moment at making that electronic. And nationally, I was on the expert advisory group to set up a national survey, which we're going to incorporate in New South Wales. And we did some piloting with iPads, and probably indicative of how difficult mental health services can be is that the only thing that came out different in the piloting of iPads as opposed to piloting with, sort of paper-based, was that people thought there was more things to do in mental health services, just simply because they got to use an iPad. But I guess my point is that with a big block in actually converting to iPads or kiosks within mental health services is that the resource implications of the hardware, actually buying the iPads. So I'm hoping that this type of conversation will get us over that particular block.
Thanks for that comment, and we won't get any commitments to capital spend on the panel, which will get me a knife attack later. But it is an important issue with with the implications moving on. But this technology is getting cheaper and cheaper. So
it is, Norman. And I think there's two aspects. One
Are you
is
about to make a career-ending statement here?
No, not at all. Increasingly, people who work in the health sector actually want to use their own device, and which is a departure from tradition where it's always been an organisation-supplied device. I think the point's well made that within the health system, that's probably an acceptable level. But when we look at how we support patients, it's when we look at the home dialysis. If that particular patient didn't have a mobile phone, we really, given the benefits of it, should loan that person a mobile phone to do that. And I think they're the challenges that we've got.
And that's what I was talking to the Minister and Mary about earlier, is flexible use of money, because you're going to actually get the benefit. Yeah. Mary McCaskill, I might just talk to you about Theresa's question about priority setting and so on. I mean, you're working in a hospital that was one of the first to be fully, or at least, almost fully electronically enabled. Almost, yes. We want to. But how do you think you should set priorities? What should be the frame of thinking for priorities of new developments?
Well, it's impossible for someone who only works
You'll need to speak up right into
It's impossible for someone who only works in one part of the system, because you only know that part of the system. So I can tell you the priorities in my emergency department, but that's of no relevance to the whole system. So we really need to have a view of the whole system. Your point about do we have relevant technology, the technology's out there, you've just got to sort of use it. Everyone's already using it at home, it's just then using it in the environment. And sometimes it's worthwhile having projects that work, like your dialysis project, which then you grow on it, rather than if you spend a long time looking at priorities, that might not have been a high priority, but it's going to work for those patients, and then it can then be springboarded off for other things that are like that.
And of course, meetings like this where you actually see the technologies mean that you can actually take other people's and just adapt them. Yes, you were very patient at the back.
Is that myself?
Yep.
Jeff Berry, I'm a consumer from southwest Sydney. Like many other consumers, I'm very interested in integrated health. And we talk about all the systems, the IT systems that are going to join us up and give us good integration. At the moment, most of our hospitals can't speak to our GPs. The GPs can't speak to the physios. We get promised it's happening, it's happening. Can anyone tell me how close we are getting to this integration, especially in terms of IT?
I think that might fall to me to answer again, Norman. I think the personally controlled electronic health record, which has been set up as a collaboration between the state and the federal government, is now operating. And in that particular record, if people have established one, you will have discharge summaries from hospitals. And those discharge summaries, when they get sent to the personally controlled record, also get sent electronically to the GP. So we have a transfer of care document that's actually going between hospitals and GPs electronically through the PCHR. We're also able, as we roll out our community health system...
But it requires the GP to be using the PCHR.
Yes, but all of the GP practice software is now integrated into linking into the PCHR. And so
I say it again, it requires the GP to use the PCHR, even though it's there. Yeah, it's been there for a long time.
Correct, yeah.
So on that issue, and given there's still a perception out there that this is not happening, the Commonwealth's spending a bit of money trying to get GPs to use it. What are the roles of local health districts to encourage GPs to be enabled at the other end and actively using the PCHR? Because you talk to GPs, they actually don't understand the PCHR, they don't understand its capacity, they think it's hopeless and doesn't work.
I think New South Wales Health's integrated care strategy is the real lever that we've needed to actually engage GPs and patients in actually making use of the PCHR. As we actually try coordinated care plans that are accessible by GPs, other services, that linked to the PCHR, we'll see some benefit and we'll see more people pick it up.
So put up your hands if you have a PCHR. Pathetic. Pathetic. You're working in the system, you all complain there's no integration or framework, and you haven't registered for your own PCHR. It takes you now about 2 minutes to do. There's about 6 steps now. It used to be a nightmare, but it's not anymore.
Could I just make one little small comment on that? My records are there, but the hospital hasn't sent anything, and I understand the hospital isn't able to, or doesn't. So, I mean, I don't believe that the hospitals are at the moment doing exactly what you think they are doing.
Yep, so you said you were from southwest Sydney? Yep, so HealthyNet had not yet arrived in southwest Sydney, so we've got it in 5 districts, so Nepean, Blue Mountains, Western Sydney,
So it's coming to Liverpool and Campbelltown soon?
Yes.
Good. Mary, did you want to make a comment?
I just want to say it's fantastic. I can see when a child comes into the emergency department, I can see their birth record, I can see when the community health nurse went to visit them with their feeding problem, and then when they come to me with their bronchiolitis at 8 weeks of age and I send them home when they're better, I know that the GP will get the letter, an email the next day, whereas I used to give them a letter and it always got lost in the handbag.
So always fine. So it does work. The vision is here now.
In relation to older people, I'd say there's a really good uptake amongst the older people who
can see the benefit.
PCA, they see the benefit. There is a huge degree of frustration that their clinicians are not using it.
And the only way to get to know it as a user is actually to be registered yourself and get the sense of it. So tonight, get it. Yes, final question.
Hello, my name is Fiona Lysart. I'm the Community Health Service Manager at Moree, Boggabilla and Mungandai. So I'm very proud to say that we use the service really well. And I'd like to say for the people that don't realise this, that it's changed not only the clients that we have, but we're also part of our community, so it's our families and it's our friends. And we have clinics such as the MSOAP clinic, where specialists come from Sydney, which is a long way away when you live at Boggabilla. And they're seen in Moree, and then later they can be seen by Telehealth. It saves these people hundreds and thousands of dollars. And also, when you're sick, the last thing you want to do is travel. telehealth has changed our communities a great deal, and I want to say thank you very much for that.
And thank you for sharing that with you. Please thank our panellists. Sorry we didn't get to everybody again, but it was important that we heard your views as well, and HealthyNet is coming to a hospital near you soon. Thank you very much indeed.